Now, Professor Renu, please join us for your talk.
So, good afternoon, my fellow Uttarakhand members here. It is good. I mean, there are 7 of us. I have an audience of 7. Sir, the बाकी number बढ़ गए वैसे. From here you can see more. हाँ जी सर. मुझे मिला के ना. मैं audience नहीं थी ना सर. So I have no financial interest. One of the reason whenever we are trying to present a talk on diabetic macular edema is like one is so UPI payment हो या पेटीएम हो, आपको पता नहीं चलता आप किसके बारे में बात कर रहे हो. Similarly, before we know, we may be talking not of anti-VEGF, but maybe using a term Avastin or Lucentis. And the mind does not recognize that you have switched from saying anti-VEGF to a trade name. So therefore, it is important that this is made clear. As I stand here, I want to acknowledge that we live in the world capital of diabetes now. We have the highest number of diabetics in the world. And the recent literature shows that 8% of the juvenile diabetics and up to 12.8% of the adult diabetics actually develop visual impairment due to DME. And if we are to say that 20% of the adult population actually has diabetes, of this 12.8 would actually lose reading, writing, vision because of the diabetic macular edema. What is diabetic macular edema? This audience is August, very learned. This is simple swelling of the retina due to the leakage of fluids from the blood vessels. And there is thickening of the basement membrane and a reduction in the number of pericytes, which results into this. Clinically, you want to classify it into mild, moderate, and severe. OCT plays a very important role now, and the only reason many a times a person like me does an FFA is just to rule out ischemic macula. Otherwise, OCT is something that we really like to see, and every time that you are doing OCT, please look at the retinal layers and look for the ganglion cell complex, the inner nuclear, and the outer plexiform layer. If there is any disruption, these are the patients where there would be some amount of residual visual loss even after appropriate or proper therapy. If a patient actually has an attached vitreous phase, a epiretinal membrane, these patients usually have a poorer outcome. So if we look at these clinical pictures, there are some patients here where there is no disruption, and these patients would actually have good vision compared to the second lot. I don't have a pointer, yeah. Compared to the second lot where there would be some loss in vision. We do want to cause a reduction in the hyperpermeability. Laser was always the gold standard for treatment. However, we realize that laser is something which is not able to restore good amount of vision, number one. Number two, there was some amount of anatomical damage, and therefore the need to use for pharmacotherapy. Even today, subthreshold laser or low fluence laser is something that one would use for a mild DME where the edema is away from the center 500 micrometer. Now, why are we talking about VEGF today? VEGF is a very important component which is present in a diabetic patient, which causes the upregulation resulting into permeability of the blood vessels, number one. Number two, it is an inflammatory mediator. And number three, it is associated with neovascularization, which is going to actually worsen the prognosis of the patient. So, different ways that we have come up with anti-VEGF are the ranibizumab, the brocilizumab, bevacizumab, and so on. Whenever we are talking about our anti-VEGFs, we need to just know that there are some which are going to just act on one kind of VEGF, these anti-VEGFs. So bevacizumab is one which will act only on the VEGF-A, while in comparison, there would be Eylea, which would actually affect or cause the down regulation of VEGF-A, B, as well as the placenta growth factor, which are again associated with inflammatory mediators. A newer VEGF, that is faricimab, is actually acting on VEGF-A and angiotensin factor 2 as well. So this actually works on two ways and two mechanisms. The cost is slightly higher right now. Hopefully, we'll be marketing at a lower price soon. A lot of clinical trials have studied different VEGFs and VEGFs comparison to the laser. They have really been compared very well. And I'll quickly go to the thing which sir wanted me to say was that if it is a patient where the vision is compromised, VEGF is usually a better choice. If the vision is really poor, that is 6/60 or low, these are the patients where you do not want to use an anti-VEGF, rather use a VEGF trap here. In comparison, if a patient who has a 6/6 vision away from fovea, do laser. If this involves even a little amount of fovea, please inject. In all patients who have a center involving DME with no traction, anti-VEGF is the treatment of choice in this day and time. In this, we need to have a monthly follow-up, a monthly OCT, and inject till we believe that the vision is improving or the OCT is showing progressive improvement with restoration of the foveal contour. There are some patients where we would find that we have given 3 injections and the vision is not improving or the macular edema is refractory. These are the patients where there may be multiple other reasons other than just the VEGF which is causing this macular edema. The best thing is to actually switch the therapy after giving at least 3 injections though, or add laser to these patients or add an adjuvant steroid to these patients. So that is the way that these patients would be treated. If you believe that this patient actually is not responding to laser as well as this, please go back, do an angiography again. Maybe you are dealing with an ischemic fovea. Now, when do you say that I need to stop injections? See, there are 2 things that we've been doing. If you find that whenever they are doing any trial, these patients are receiving somewhere close to 11 to 12 injections in 2-year time. Our normal patient does not go through that. Economics plays a very big role in our country. So what we realize is, please go and inject at least 3 injections and then as and when needed. Because these patients may not be able to afford prolonged or multiple injections. I already mentioned this. Now, if it is an ischemic fovea, as you would see, I know it is boring. I'm so sorry. Every time that I see a FFA with a nice fovea like this, I start counting the capillary dropout areas to see, should I call it grade 1, grade 2, grade 3, grade 4, injection lagana hai, PST lagana hai, intravitreal lagana hai, ki anti-VEGF dena hai. So this is the way I see it. I'm so sorry. But this is how it is. That for us, this little black spot is so important. Because this is what is actually determining that reading, writing, vision. And this holds so much of importance as a person who works with retina. Every time, the only thing I want to go back is go and see the fovea. See the fovea, see the fovea, see the fovea. That is the way it is. There are some special circumstances where a patient may have diabetic macular edema if the patient is pregnant. Now, if the patient is pregnant and she has diabetic macular edema, these patients should rather be injected with a steroid than be given intravitreal anti-VEGF because there is no safety profile available for these patients. Similarly, if the patient has had a recent stroke, though there are some studies which say that this VEGF may cause an increase in risk for strokes, which is very rare actually. It is less than, some studies say less than 3%, some say less than 1%. But it is still there. So it is better to inject with a steroid here. The third category which is missing here is patients who are waiting for transplant. Patients who are waiting for renal transplant, injection of anti-VEGF have been associated with higher transplant rejection. Therefore, it is better to treat these patients with steroids than treating them with anti-VEGF. This is something which sir wanted. Sir ke 4 question. Focal edema, please do laser. If it is mixed edema, give an injection of anti-VEGF. If focal leakage remains, do focal laser here. If it is diffuse edema, please give anti-VEGF. Persistent, go ahead, give some steroids here. So that is how it is. Thank you very much.
Thank you, Professor Renu.
Actually, he is doing it there.
We enjoyed your talk, and after that, we are lucky enough to have Gaurav here. He could find time. He'll be speaking on new advances in corneal cross-linking.
So we have one more audience. Thank you very much.
So all points were very relevant, Dr. Renu. Just one point to add that anti-VEGFs can also cause renal problems.
Yes,
Not
yes,
only in renal transplant patients, but anti-VEGF, there are studies in which they've shown that anti-VEGFs can cause nephropathy. So we have to be very aware of that as well.
Actually, both anti-VEGFs have been associated with slight increase in blood pressure, systemic blood pressure. The second thing which happened with me actually was that though you keep hearing about brocilizumab, but what I understand is if your patient, whenever you're doing a fundus examination, even if you find a second order blood vessel appears occluded, these are not the right patients for brocilizumab at all, even if they have DME, because these patients do end up having vascular occlusions. So even if second order vessel is occluded, don't inject there. Thank you.